Hi there. Today I wanted to talk about 5 things that I wish every therapist knew about dissociation. The first is that dissociation isn't always obvious, as is portrayed sometimes in media, movies, and whatnot. Um, so switching isn't necessarily dramatic. Amnesia can be subtle. Internal conflict can be misinterpreted as resistance, and stabilization requires a different clinical lens. So the first talking point that I wanted to, dive into is around the subtlety of dissociation. I think we've been fed some misinformation for a long time about what it looks like in movies and whatnot, where we see these big dramatic changes in people, and then that somehow became the narrative in terms of what dissociation looks like in general. So dissociation does exist on a continuum. It isn't synonymous with DID specifically or obvious switching. A client could be dissociating while still seeming calm, coherent, and fully engaged. So we want to be able to look beyond whether or not the person, or look beyond the question of does this person dissociate and ask how dissociation might organize this person's experience. So obviously that's a question that has a greater depth. So subtle signs can include losing track of time, difficulty accessing autobiographical information, feeling disconnected from emotions or the body, feeling unreal, feeling detached from emotions in the body, feeling like there's an awareness that something happened, but it doesn't feel like it happened to the person. And sometimes that language is very explicit, like that didn't happen to me, that happened to a part of me. And that separation can feel very real. But you wouldn't know that unless you had a conversation with somebody. Um, Another example is I know what I should feel, but I can't access the feeling. So this frustration of reaching for an emotion that's supposed to apply to a particular context is another example. So dissociation can become more visible when the client approaches emotionally meaningful material, and what the dissociation looks like as that happened, of course, can vary from person to person and moment to moment. So sometimes it just looks like some quiet, sometimes it looks like distractibility, sometimes the eyes might look a little bit glazed over. You might detect some subtle shifts in the room, etc. But as you approach more complicated content, dissociation might move in as a sort of a rescuer, given that that is its job. But the absence of obvious switching or obvious amnesia does not rule out clinically significant dissociation. So we don't want to just assess whether dissociation is present. We want to assess how the client's experience is organized across states, time, memory, identity, and affect. The second point is switching isn't necessarily dramatic. I touched on this a little bit, but just to expand it a little bit more, of course, it's more interesting if when we're watching a show and we can see obvious movement between parts of self. That is not how it looks typically. And in fact, a lot of folks, particularly adults who live with OSDD or DID, will put a great deal of effort into hiding their condition from you, from the world, and from themselves. That's the point of those of structural dissociation in general. So back to switching, it doesn't have to involve a dramatic change in voice or changing clothes or huge shifts in mannerisms and whatnot, or someone announcing that they've switched. So, typically, there's not an awareness until later in treatment that switching has happened. And switching can be subtle enough that the clinician might interpret it as a fluctuation in mood or ambivalence, a lack of motivation, personality traits, or relational dynamics. So we want to look for patterns over time rather than watching for dramatic moments, because again, that's not typically how it's going to show up. A client may use different language, express contradictory preferences in terms of what you already knew about your client. They may relate to you differently, have access to different memories, different capacities or skills, or experience a different relationship to the body. And so sometimes the most important clue is not what has changed, but what has become inaccessible. So always looking for what's missing instead of what is there. Excuse me. Um, so, for example, a client might say, yesterday I really wanted to work on this. Today I don't understand what we're talking about or why we're talking about it. So that's some ambivalence obviously showing up. I know we discussed that, but I don't feel like I said those things. I don't remember that. I don't recognize myself when I look in the mirror or when I look at that entry. So these are, again, statements reflecting an internal experience that would not necessarily be visible to an observer. So again, don't just start looking for alters simply because a client has an inconsistent presentation. Our job is to assess patterns without imposing an explanation. Amnesia can be subtle. Subtlety is obviously a theme. This one can be particularly powerful for clinicians. They may expect, when we start to do an intake or we start working with our clients, in the beginning, we might expect complete autobiographical blackouts in somebody who has a dissociative disorder. But more commonly, memory fragmentation it's fragmentary. It's state dependent or difficult to recognize. It's not super obvious. So some examples might be remembering the event, but not the emotional experience. Knowing that something happened, but not having a sense of when. Remembering facts surrounding the event, but not the context per se. Someone told you something, but not remembering the conversation, discovering notes, texts, purchases, or emails that are not remembered by the client, or remembering an event differently depending upon emotional states. And this is again state-dependent learning, something that we remember things in one state when we return to that state. Clients may also compensate for memory gaps without consciously recognizing them. So they might rely on calendars, texts, their partners, notes, or routine or other people telling them what has happened. Some clients might describe themselves as having a terrible memory rather than themselves recognizing it as possibly dissociative amnesia. So we want to ask about time and continuity, not just childhood trauma. In fact, as we assess and we start approaching that content, we want to do so respectfully and carefully. So again, assess what's missing, not only what is remembered or disremembered. I mean, that is what's missing. What is disremembered is missing, but we want to look at everything in a larger context and begin to create a formulation based on various pieces of evidence that we collect during our initial meetings with people and over time. Internal conflict, this is the next one, can be misinterpreted as resistance. So what looks like resistance to some may represent competing protective responses within a person's internal system. So a client might say, I want to get better, but I can't make myself do it. Part of me wants to talk about this, and another part of me absolutely does not. I know this relationship is bad, but I can't do anything about it. I can't change it. So a traditional formulation might be, again, resistance, avoidance, a lack of motivation, non-compliance, which I'm not looking for compliance anyway. That's not something we're looking for in mental health treatment. Ambivalence or well, I would leave it there, ambivalence. So what we're looking for then is what makes sense about this conflict. And I try to do some internal mediation and discovery. Like I'm not inserting myself into somebody's internal life, but I am going to approach it with curiosity and try to understand both sides as an internal mediator. And so different self states may, like as we explore internally what's going on, we may discover that different parts have different goals, fears, memories, beliefs, etc. And a protective part may be perceived trauma processing as dangerous, even when another part desperately wants relief. And this is a very common and very painful experience for a lot of people, where the exiled parts or the highly traumatized parts of self are really seeking relief and comfort, while protectors understand also that moving into that material too quickly can be dangerous for the client. So there's an internal battle around what to do with the trauma content that the client has to work through. And sometimes that's a long piece of the work and takes a lot of time. So we need to be patient and understand the root of the conflict and how to mitigate it. Internal conflict is information, so we don't want to try and eliminate it before we understand it. We really want to work within the system and support it in greater cohesion between parts and understanding. Um, Stabilization requires a different clinical lens. So it's not simply about teaching grounding skills before trauma processing. And I don't want to say that that is a simple task because it is not. But it is different in this population. So it's not just about symptom reduction. It's for dissociative people. It may involve working on internal communication first and internal awareness, because, the whole point is to not be aware of what's happening internally during, while trauma is being experienced. And as we approach safety, then we can begin to explore what the internal life looks like a little bit more. But safety is a precursor to that. We might be, as part of stabilization, work on developing greater cooperation, increasing tolerance for other parts and between other parts, creating internal safety, negotiating boundaries around trauma and how to navigate that content and material, increasing continuity across time, and developing a shared understanding of the system. Those are some really important stabilization I guess, milestones that we need to embrace as a clinician. And grounding doesn't work in the same way with this population because we're asking somebody who is detached to become attached. And that detachment is a very important safety valve for them. So we don't want to just ask them to get into their body all the way and feel all the things and be rooted in their body. We first need to help them become familiar with the body and familiar with the here and now and all of that. And that might need to be titrated. Some grounding and mindfulness can increase dissociative responses, and we're asking a dissociative person to use their mind to change the way they feel in the moment or something like that, whereas mindfulness can be sort of just like, or it can very much mimic the dissociative experience. So we need to be nuanced when we're using some of these traditional grounding techniques with structural dissociation or dissociation in general. And so generally for dissociative clients, stabilization isn't simply getting the client calm enough to process trauma. We're doing a lot of work internally and building infrastructure to create safety, cohesion, and predictability as we move towards that trauma. And all of those things should be in place before we do that work. And I often say the first third of the work is by far the longest and most challenging. Once we start dipping our toe into the trauma work, we've already supported a lot of relief and awareness and all of that. So don't rush towards the trauma. I hope that's helpful, and I will talk with you soon. Take good care.